So I'm very happy that I can be presented a tiny bit of the work that we have been doing in relationship with drug use and migration in the European Union. Because one of the things that they are noticing is like depending on the big impact that migration is having, not only intra-European migration within the continent, but also from other places. All of the studies that they were looking into, they were completely inconclusive or were not bringing relevant information. So within the scope of a project called SEMIT, in which several organizations, civil society organizations, 2 academic organizations, and us as European network, we're having a look into addressing what are the gaps of knowledge, the gaps of also support and care. And one of the things that we did as part of the project is a community-based participatory research conducted in Amsterdam, in Athens, in here, Berlin, in Paris, with 98 participants from 43 different countries. So one of the things that for us it was important is to give, first of all, training to community itself to be able to conduct the research, and then from there to be really able to gather and build the capacity to understand exactly through the lens of communities themselves what is happening. In Amsterdam, which is what I'm going to be focusing a tiny bit, the communities we were working with, they were like intra-European Union labor migrants, particularly from Poland, from Bulgaria, and from Russia, and also from Ukraine. We also were having another big group of Arabic-speaking, mainly LGBTQ people, and the other part that we're having was Spanish-speaking migrants. I'll do a very quick summary of some of the major barriers and challenges that these communities were experiencing. One of them is homelessness, which is one of the biggest issues that is happening. And even though people from the European Union in principle should have a bit of a better access, we see that in reality still in practice that doesn't happen. Barriers to health services are many, but one that is significant and I will highlight is a very limited access to OET. And we are speaking of Amsterdam, the Netherlands. But in this particular case, access to healthcare and social support is conditioned by having an insurance. And to have an insurance, you have to have registration in the municipality and having a bank account. So we enter into this cycle of conditions that start creating an increased system of inclusion. Also, we see that there is big cultural and language barriers that they are hindering the accesses. And also we see that there is many compound forms of stigma that are coming in relationship to forms of racism, in forms of, in the case of LGBTQ community, racism, LGBTQ stigma, and drug use stigma. Something that we see is like these communities, they come with a very limited network of support. In the case of people from Eastern Europe, it's a bit less because normally they are coming more in groups of friends and they have a certain network that allows, but actually these networks are very fragile, particularly when it comes to drug use, and generates a lot of distrust in the communities. And also we are seeing an incredible need for mental health care. And particularly one of the things that we are noticing that the relationship between mental health care and encounters with law enforcement are really big because, as I was mentioning, not having access to mental health care involves that for people to have that access, they need to be building a police file in which at a certain point they will be declared as a threat to themselves or threat to the community. And then on that particular moment, they might have access to an emergency mental health care, but that means that they are going to be creating a risk of making more complicated the residence permits, which already are complicated and unstable. Substance use, the main thing that I will highlight is polyconsumption, mostly inhalation, nasal and oral. In the case of heroin, still remains mostly injected. But one of the things that is a big mix of substances. And then particularly in the LGBTQ community, we have seen a big increase of 3 MMC injected. Some of the takes that we are coming in here as some sort of a policy or some sort of a service recommendation. We see that one of the things that we need to still be doing is improving the availability and the accessibility to harm reduction services, because mainly those are the entry points in which these communities aren't accessing any care or any support. We see that we need to be expanding the access to the treatment and mental health care. We see that also is very important inclusive co-creation with market themselves, and that's some of the work that we are doing, because specifically there is big cultural barriers and there is big cultural shocks that make it very complicated, and also because there is a lack of information regarding the few services that exist. So it's very important to be able language accessible materials that people can be accessing. The last part is human rights in integration focus, and with this we see that sure, there is a possibility for problematic drug use, but in the particular case of these communities, what we see is that we need a full harm reduction spectrum that actually is tackling the conditions that generate vulnerability, not necessarily the substance use, such as labor integration, housing, and other forms. And with this is the minutes.
Fantastic. You spoke incredibly fast.